This conference will now be recorded.
Okay, so we will start today. See, today's topic, this is a sepsis talk from Jan 2020. The title of the talk is this is current management and controversies. So half of the talk is about some controversy, half or last around almost 30% talk is about controversies. I don't think they will ask more question on this. But the current management. So what is important in this talk is the percentages, what are the typical news score to have included, and the management part. So actually this talk is not very important, barring a few 4 or 5 points, remember well. Okay, so first is the definition of maternal sepsis. According to recent WHO, maternal sepsis definition is, it is a life-threatening condition defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, and postpartum. So here they have included, remember well, maternal sepsis, it includes post-abortion also. Okay, so that period also they include in maternal sepsis. Next thing is, there are some numbers what they have given. So it is the important cause of maternal death in UK, 8% risk of mortality in HIC. HIC means high income countries. So risk of mortality is 8% in high income countries. Morbidity to mortality ratio is 50:1. Okay. And prevalence of puerperal sepsis, WHO prevalence of puerperal sepsis is 4.4. Okay, so 4.4% people have puerperal sepsis, while more burden is with low middle income countries, that is 7%, while high income countries it is around 1 to 2%. And the pregnancy related sepsis. So pregnancy related sepsis means the sepsis conforming to the wound infection, genitourinary infection, and mastitis. These are the three. Okay. So genitourinary tract, surgical site infection or wound infection, and mastitis. So it contributes around 11%. But when all infections are evaluated, it will contribute for 25 to 40% of maternal mortality worldwide. So sepsis mortality worldwide is around 25 to 40%. And the fetal risk are miscarriage, stillbirth, and preterm birth. Fetal risk are miscarriage, stillbirth, and preterm birth from the sepsis. So in high income countries, stillbirth because of sepsis is around 10 to 25%, while it is around 50% in low income countries, low and middle income countries. So basically what happens in pregnancy, the diagnosis becomes difficult of sepsis because what happens is maternal physiological and immunological adaptation, they are designed to facilitate the development of fetus. So it may impair maternal capacity to respond to infection. So exactly what is it is? So physiological changes that occur to promote the maintenance of healthy pregnancy, those may mimic early sepsis. Okay. So those changes in pregnancy which are necessary for this fetal adaptation. So they may mimic early sepsis and make it becomes they make the diagnosis difficult because there is as you know there will be altered innate immunity in pregnancy. So pregnancy, as we know, it is a state of immunosuppression. So again it makes the pregnancy infection prone. Also another thing is this nitric oxide is upregulated in sepsis and it causes this smooth muscle relaxation, vasodilatation. In the pregnancy itself, again, prostaglandins and nitric oxide are upregulated by estrogen. Okay, so these are actually required for developing fetus, but again, it makes the pregnant woman more susceptible to hypotension in response to infection, causing multiple organ dysfunction. So multiple organ dysfunction, hypotension, it becomes more common during sepsis, during pregnancy. Okay. So instead of non-pregnant women, this hypotension and multiple organ dysfunction is more common because of sepsis. So these are the changes. You can see on the left side the changes which are normal to the pregnancy and the changes which are common to the which occurs in sepsis. So you can see almost majority of changes what are occurred in pregnancy, the similar changes can happen during sepsis, and that in early cases this makes the diagnosis difficult, and finally as an added effect or cumulative effect, finally it may lead to multiple organ failure, as you can see at this end of the slide. So cardiovascular, rapid collapse, respiratory, pulmonary edema, decrease in oxygenation, ARDS, okay, and decreased ability to compensate for metabolic acidosis. Renal acute kidney injury because of increased plasma flow along with renal ischemia. Also coagulation changes occurs in pregnancy and also because of sepsis. So it may lead to the increased microvascular thrombi, microcirculation dysregulation, end organ dysfunction, tissue hypoperfusion. So these all the things, pregnancy plus sepsis, they leads to cumulative effect and potentiate the consequences of sepsis. So how you're going to diagnose this sepsis? So there are different scores which are given as a, so I don't think you should remember these scores. No need to remember what are exactly the scores is, but you should know the names of scores and grossly what parameters are included in that score. So modified, obstetrically modified SOFA score is, it is respiration, coagulation, liver functions, cardiovascular function, CNS, and renal. So it is actually multi-organ score. So there, oxygen concentration, platelets, bilirubin, mean arterial pressure, CNS, and renal function they will evaluate. It is obstetrically modified SOFA score. While it is obstetrically modified sequential SOFA score, it is known as Q SOFA score. Okay. So this Q SOFA score, this is based on only 3 parameters. So these 3 parameters is systolic blood pressure, respiratory rate, and altered mentation. So this is the most easiest score to apply so that all paramedics can also apply this score, and you can, so the triage becomes very easy. So even midwife can apply this score and the triage becomes then very easy for this sepsis patient. So score more than or equal to 2 is associated with increased risk of mortality. So systolic blood pressure 90 they have taken as threshold, respiratory rate is 25 as threshold, and mentation alert and non-alert. Okay, so any score more than or equal to 2, it carries increased risk of mortality. Now how you are going to prevent the sepsis in or maternal sepsis? So peripartum period or antenatal or postpartum period, how you are going to prevent this sepsis? So first thing what is accepted by NICE is asymptomatic bacteriuria screen in every pregnancy. So asymptomatic bacteriuria screen is recommended in every pregnancy. Next thing what is recommended is, as we all know, antibiotic prophylaxis during cesarean section. And the third thing which they have recently included in the guidelines is antibiotic prophylaxis during operative vaginal delivery. So this is the recent change they have made and which also responsible for decreasing the sepsis. So exactly what happens during vaginal delivery, the rate of infection or incidence of infection will be 5.5% only, while it increases up to 16% in case of operative vaginal delivery. So when you give antibiotics, 1 dose of intravenous antibiotics around the delivery, that is 3 hours after delivery, median they have taken as 3 hours after delivery. So it leads to 56% reduction of maternal infection and also associated with significant reduction in perineal wound infection. So because of this, it will finally decrease the maternal sepsis cases. So they have recently included this antibiotic prophylaxis during operative vaginal delivery. Previously, it was recommended that no antibiotic prophylaxis is required, but now new guidelines, they have recommended this antibiotic prophylaxis. Now, how you are going to diagnose this sepsis? So this is the question in I think one book they have asked. So cultures, we know according to sepsis bundle, we have to send the cultures before starting any antibiotic. But when you see the evidence, you will find out that only 30 to 40% of blood cultures will be positive in patients with severe sepsis. And then as we know, it requires at least 24 hours to results become available. So till that time, we have to rely on empirical antibiotic therapy, right? So, exam point of view, this was the question somewhere. So, only 30 to 40% blood cultures are positive in patients with severe sepsis. Okay, so how you are going to improve this thing, and you can diagnose it earlier, sepsis or resistance to antibiotics. So resistance to antibiotics can be diagnosed by either polymerase chain reaction or mass spectrometry. So mass spectrometry is metric assisted laser desorption or ionization using time of flight mass spectrometer. So I think you don't need to know all these details, but these are the few new things, that is PCR and mass spectrometry. These are actually designed to know the exactly antimicrobial resistance. Okay, antimicrobial resistance. These are quick, accurate. But one thing is expensive, and another thing disadvantages is it may identify non-pathogenic organisms also. So actually currently these few new techniques are not recommended for diagnosis of sepsis in pregnancy. But these new techniques are available. Remember those things. Other biomarkers, what you have to remember is C-reactive protein, procalcitonin, and third thing is lactate. So there are three other biomarkers which are used to diagnose the maternal sepsis. So first is C-reactive protein. It is a non-specific thing. The exact use we can't correlate with the infection because it is very non-specific. Procalcitonin, it is specific for bacterial infection. And lactate is the thing that we use to diagnose maternal sepsis. So more than 2 is severe sepsis. It is an indication for admission to critical care. And more than 4, it is septic shock. More than 4, it is septic shock, and mortality is up to 46% when the lactate level is more than 4. So for management of sepsis, there are two approaches. That is, one is resuscitation and another is source control. So to avoid multiple organ dysfunction, you have to do resuscitation, and then we have to do source control also. So for resuscitation, so basically for these two things, there are sepsis 6 bundle. So this sepsis 6 bundle means it is the first thing is for the diagnosis, and other thing is for the treatment part. So diagnosis part, it is the cultures, blood lactate level, and hourly urine output. So this hourly urine output, it comes in diagnosis because to know multi-organ dysfunction. And treatment part is oxygen, intravenous fluid, and antibiotics. So these 6 parts, they form the sepsis 6 bundle, and it is a part of SSC bundle, that is say saving sepsis campaign. Okay, so SSC is a saving sepsis campaign, and when you apply this sepsis 6 bundle, there is 25% relative risk decrease in mortality. So 25% decrease in mortality with application of this sepsis 6 bundle. Remember well. So now for resuscitation, this saving sepsis campaign recommends resuscitation at the rate of 30 ml per kg, while RCOG recommends 20 ml per kg because increased risk of pulmonary edema in pregnancy. So RCOG recommends resuscitation at the rate of 20 ml per kg, while the saving sepsis campaign recommends 30 ml per kg initial IV fluids. Then so this should be initiated without any delay for management of septic shock when there is lactate level is more than 4, and the resuscitation should be aimed to achieve mean arterial pressure more than 65. And what is the drug of choice? It is crystalloids are the primary choice of intravenous fluid for sepsis. Now for source control, as we know, we have to start in antibiotics. So initiation of antibiotics is the major part of source control. So this SSC recommends combining 2 classes of antibiotics only for the treatment of septic shock. So actually it recommends only 2 classes. But what happens is, as we know, the most common cause of maternal sepsis is E. coli and group B Streptococcus, while most severe outcomes, these are associated with E. coli and gas. So empirical antibiotics should be started to cover gram positive, gram negative, and anaerobic as per the local microbial susceptibility pattern. And finally, when the culture results come, de-escalation should be done according to the culture results. So first, empirical antibiotics should be started to cover gram positive, gram negative, and anaerobics. So if there is delay in this source control, so if there is delay in starting of antibiotics, the 28-day mortality rate increases from 26 to 42%. if there is delay in static antibiotics. So first is source of control should be initiation of broad spectrum antibiotics and then de-escalation according to the culture results. Now, what are the indications for transfer to intensive care unit? So for cardiovascular, it is hypotension, raised serum lactate persisting despite fluid. So when there is lactate is more, despite you give IV resuscitation, so which requires inotrope support. So for inotrope support, you have to shift that patient to ICU. Respiratory, any respiratory complication like pulmonary edema, mechanical ventilation, or airway protection. For dialysis, for renal, you have for dialysis. So for multi-organ failure, basically what you have to remember is for multi-organ failure, you have to shift that patient to ICU. So neurological, any significantly decreased consciousness level, miscellaneous multi-organ failure, uncorrect acidosis, and hypothermia. So for all this, ICU management is required. So now, once you complete the treatment, so regarding controversies, so basically, what they have found that the patients, for many patients where the sepsis bundle has been initiated, they may not have an infectious etiology. Because in labor, maternal pyrexia is usually common, that is associated with epidural analgesia, prolonged labor, or ambient temperature. Or it can, and also tachycardia is a result of dehydration, the work of labor, and sometimes because of other pathologies like cardiorespiratory, metabolic, or endocrine pathologies. But as we know, also these two things, they also suspect chorioamnionitis, like maternal pyrexia and tachycardia is suggestive of chorioamnionitis. And this chorioamnionitis is associated with increased neonatal morbidity and mortality. So for that thing, any maternal pyrexia plus tachycardia, there should be low threshold to commence empirical broad spectrum antibiotics, usually for a preterm labor less than 34 weeks. So where there is greatest risk of early onset sepsis. So whenever there is a preterm birth and any signs of maternal pyrexia and tachycardia, you should go with empirical antibiotics. And as we know, preterm birth is an indication for IAP. Now, glycemic control, there are controversies whether to control the sugar very tightly or you can use some, because there is a very difficulty in controlling the sugar and there are conflicting results on the impact of tight glycemic control versus standard care. But currently, what is the aim is control the blood sugar level to less than 180. Okay, this would be unlikely to adversely affect baby, but uncontrolled hyperglycemia will be a greater threat. So better to control the blood sugar levels till 180. So this target you should remember. Also steroids. So steroids, RCOG guideline doesn't recommend steroids for the treatment of sepsis. Okay, so steroids for the treatment of sepsis is not recommended, but you can use the steroids for lung maturity and when the patient is having other conditions like any connective tissue disorders, autoimmune disorders, or severe asthma. So for that thing, definitely you can use steroids. Oxygen, you have to administer oxygen to achieve a saturation more than 94. Okay, and when the patient is critically ill, you are going to do this invasive monitoring where you have to achieve the oxygen saturation in the veins at 65 or central venous oxygen saturation is 70%. Okay, so mixed venous oxygen saturation at 65 or central venous saturation at 70. Now, vasopressor, when you have to use this, as you know, when you are giving the IV fluids and despite that you cannot maintain the mean arterial pressure. So in that case, you may require to use vasopressor, okay, and or inotropes. So when cardiac output has been compromised, you have to use. So now this is the one thing that is the new, that is levosimendan. Levosimendan, it is a new inotropic agent which vasodilator properties and also it has anti-inflammatory and antioxidative properties. So levosimendan is a new drug which has inotropic, anti-inflammatory and antioxidative properties. It has been shown that it is useful for peripartum cardiomyopathy also. Okay, because it improves left ventricular ejection fraction. So it can be useful for peripartum cardiomyopathy, but till now there is a lack of safety or efficacy evidence. Okay, so it is not currently recommended to use this drug in obstetrics. Remember well, but the drug name is levosimendan because you may get somewhere this question. Then IV immunoglobulins. So IV immunoglobulins can be used when there is severe invasive staphylococcal or streptococcal sepsis, that is endotoxic shock. So in that endotoxic shock, you can use IV immunoglobulins. Why? Because there is dysregulated cytokine release during sepsis associated with endothelial dysfunction that will lead to hypotension, hemoconcentration, edema. So this IV immunoglobulins may function by neutralizing these antigens and inhibiting cytokine production. But there is currently little evidence to see its use during pregnancy. But still they are not saying that it should not be used. So it can be used. Now ECMO or extracorporeal membrane oxygenation. So here it has been used for either cardiac or respiratory failure in small number of patients in pregnancy because of severe sepsis and septic shock. And the outcomes what they have found, it is generally good with good recovery of cardiac function. Fetal survival rate is 70% and maternal survival rate is around 80%. So it is as compared to the non-pregnant woman. So extra ECMO can be used. So here whatever the controversies they have discussed is regarding first is steroids and another thing is sugar levels. So there are some controversies, but IV immunoglobulins you can give, extracorporeal membranous oxygenation you can give. Levosimendan, there is no evidence on safety and efficacy. This is regarding the sepsis talk. There is nothing much. So this SOFA score you should remember. Okay. And the treatment bundle and the relative numbers. These are the only thing that you should remember. Okay. So coming to the question. This is the question. 35-year-old woman, 34 weeks pregnant. She is admitted with left flank pain, pyrexia and hypotension. Blood, protein and nitrites in her urine. She started on gentamicin and pomoxiclav for treatment of sepsis due to left pyelonephritis. What fluid resuscitation regime you will use? Yes. Now there is only two things. There is the choice between the confusing thing is D and E. But as you know, RCOG recommends 20 ml per kg. So you should go with D. Okay. SSC recommends 30 ml per kg. RCOG recommends 20 ml per kg. You are giving MRCOG exam. So go with D. Okay. You have to follow what RCOG says. Okay. Next question. 35-year-old woman admitted for induction of labor following spontaneous rupture of membranes 48 hours back. She feels generally unwell with abdominal pain and green vaginal discharge, pulse 110, BP 90/55, temperature 38.3. Started on high flow oxygen, IV fluid, IV antibiotics. She is catheterized and blood cultures have been taken. What is the most appropriate next investigation? You all know now. I don't have to tell you. Yeah, it is lactate. So these are only the two questions which are there in the actually strategy talk this thing. So definitely one question will be there in your exam. Remember well, one of these two questions will be definitely there in your exam. Again, that blood culture question and mortality question. These are the two questions that can come from this talk. Okay. So this is regarding the talk. So we'll stop here today. Now, I think you don't want this electrosurgery talk, correct? So what we will discuss next is October talk. We will start discussing October talk, okay? October 19th. Okay, then bye for now. Any
Okay,
doubts?
ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am. Ma'am, is there
Thank you.
discussion tonight?
Yes, we will do the recalls, no? 2007.
What time, ma'am?
March. Yeah, 9 o'clock we will start.
Okay, ma'am. Thank you.
Okay.